So this is Nursing 2533, Process of Human Diseases 1, Unit 10. It's on endocrine disorders. Now, the learning outcome number 1 that's posted on Blackboard is to review the workings of the endocrine system. We did this in AMP, AMP1 in some detail. It's in chapter 39, so I'm going to leave it up to you to review. So we're going to actually start out by talking about diabetes, which is learning outcome number 2. But before we do that, we have to look at how glucose is dealt with in various states and at various times in the body. So these figures are right out of your textbook, and we'll follow along. We'll talk about it. So when you have just eaten, so you're in the fed state, you've just been fed, what happens is the glucose leaves the digestive tract, goes into the bloodstream. There's glucose goes into neural tissue, which it freely does. Glucose doesn't need insulin to enter neural tissue. Neurons burn glucose as their primary fuel. Because glucose burns is oxidized into carbon dioxide and water, there's no waste products from it that are harmful to the neurons. So neurons use glucose. The increased blood sugar coming from the GI tract causes the pancreas to release insulin, and insulin makes a couple of things happen. So insulin causes the liver to undergo glycogenesis, to start storing some of this glucose as glycogen. It also goes into adipose tissue. Insulin promotes lipogenesis, making fat from the glucose. And it opens the door to facilitate diffusion of glucose into muscle tissue, heart tissue, other tissues in the body, but primarily the tissues that use a lot of glucose. So glucose normally can't get across the cell membrane, but the diffusion of it is facilitated by channels that open in the presence of glucose. So it's a door that opens with glucose. Glucose is the key. And you'll notice that glucose is entering the bloodstream and it's leaving the bloodstream in pretty much equal amounts. And insulin is what facilitates that. In the fasting state, the opposite is happening. Now, the neurons still need glucose. The muscles need, and heart and other tissues need glucose. But the glucose has to be supplied by the liver and by adipose tissue. So the pancreas releases from its alpha cells. Insulin is released by beta cells. Alpha cells release the hormone glucagon. Now, glucagon promotes glycogenolysis and gluconeogenesis in the liver, which puts glucose from the liver back into the bloodstream. It also causes adipose tissue to break down and release free fatty acids. Now, free fatty acids can be used and oxidized to make ATP in most tissues. So the glucose goes into the neural tissue, the glucose goes into the other tissues, the free fatty acids go into the other tissues. Everything is oxidized and made into ADP, or ATP rather. That's, again, normal when you haven't eaten, when your GI tract is empty. Now, before I move on, the free fatty acids, as they're released, also have a byproduct called ketones. And so there's an increase in ketones when that happens. In an exercise state, on an empty stomach, more glucagon is released. There's still some insulin because the pancreas is functioning normally. Lots of gluconeogenesis, lots of glycogenolysis in the liver, producing glucose, lots of free fatty acids being produced by adipose tissue, glucose going to the neural tissue, free fatty acids and glucose going to the other tissues and producing ATP. And it all adds up. There's a balance there, that the amount of glucose going in and the amount of glucose leaving the bloodstream is balanced. Now, when we have type 1 diabetes, well, let me digress for a second and say that if glucose is the fuel, and in order to get into the cells of most tissues, not neural tissue, excuse me, we need to facilitate the diffusion. We need to open a gate, open a door. Insulin is the door that, or is the key that opens the door. Type 1 diabetes, we've lost the key. In type 2 diabetes, the locks get changed. And I'll refer back to that analogy a number of times. So in type 1 diabetes, the pancreas is producing no insulin at all, which means that glucose can't get into tissue cells, can only get into neurons. But we have glucose being produced or being introduced by the GI tract by gluconeogenesis and glycogenolysis. Right? Fatty acids are being liberated because glucagon is being released. Free fatty acids and keto acids end up fueling the tissues. Keto acids fuel the neurons, which is not ideal. Free fatty acids go into the liver where they come out as keto acids, as ketones, and more glucose. They're converted via gluconeogenesis. And so what we end up with is an input of glucose here and very little glucose coming out. So the level of glucose increases in the blood. In type 2 diabetes, we're still producing some insulin, but not as much, but we have insulin resistance. There are fewer doors to facilitate the diffusion of glucose into the tissues. So what we get is glucose coming in from food, glucose being made by glycogenolysis and gluconeogenesis, some glucagon, a little bit of insulin, glucose going into the neural tissue, and a little bit of glucose going into the muscle tissue, and some glucose going into adipose tissue to be stored as fat. So a little bit of lipogenesis. There's more glucose entering than there is leaving, so blood glucose levels are high. Now, I'll talk more about it in a couple of slides, but one of the issues here is that This increased amount of glucose causes the insulin to be released, but the receptors for insulin on the tissues get downgraded. When they get downgraded, the sugars don't move, which stimulates the release of more insulin, which then doesn't help the situation because the receptors are reduced. There's more insulin resistance. And eventually, the pancreas stops releasing insulin to that level of sugar because it's proving useless. And this is when we get this insulin resistance. Okay, so in type 1 diabetes, this is the ones that happens in kids and young people, but it can occur at any age. And really what it is the beta cells that make insulin get destroyed. So no insulin is produced at all. Happens in women more than men, whatever. It can happen to anybody at any age, more commonly in younger and more commonly in women. Now, a lot of people with type 1 diabetes actually have an autoimmune attack on the beta cells. So it's immune mediated. And the beta cells are destroyed with autoimmune issues. Anybody that doesn't have type 1 diabetes from that has what's called idiopathic type 1 diabetes, which literally means we don't know what's causing it. Something has caused the destruction of the beta cells. When the beta cells are gone, no insulin is made, so there's an absolute insulin deficiency. And then glucose can't get into muscles, into heart, into adipose cells, into the other tissue cells that have those insulin receptors. But the liver continues to produce glucose, and the glucose can't go away. So you end up with hyperglycemia. The excess sugar in the blood then ends up in the urine. But now it's a solute in urine that isn't supposed to be there. So it changes the osmolality of urine. When that happens, you're unable to concentrate the urine. Urine becomes more dilute because you've screwed up the osmosis, especially at the distal convoluted tubule. And there's an increased volume of urine, so people pee more, and you end up with polyuria. Along with the polyuria, then, this leads to a hypovolemia. The amount of fluid in the person goes down. Blood pressure issues, things like that. So when you see somebody with type 1 diabetes, the classic things that you see are the 3 Ps. The things that they complain about are polyuria. They pee all the time. As a matter of fact, diabetes means pees all the time. Diabetes mellitus means pees all the time. Sweet. Meal means honey. So you get polyuria, which then leads to hypovolemia, which leads to polydipsia, which means an increased thirst. So you're peeing a lot and you're pretty thirsty. But you're in the presence of all the sugar, the tissues are still starving. They're not getting the glucose they need to make ATP. So eating behavior goes up because there's not enough ATP being made, and your brain reads that as not enough food. So your eating goes up. That's called polyphagia. So polyuria, polydipsia, polyphagia. Pees a lot, drinks a lot, eats a lot. And then we see high blood sugars levels, right? So we end up with this hypoglycemia. And that's really the causing the 3 Ps. So we start to use the fat that's stored in our body. We catabolize that. It's a lipolysis, and to make free fatty acids. But we also end up with these ketone bodies. And ketones are actually the chemicals that make fruits smell. So when somebody's in ketoacidosis, when they're producing too many ketones, their breath starts to smell very fruity. Oftentimes it's like bananas, like overripe bananas. Another smell that you'll get is the simplest ketone is acetone, and so it smells metallic or like a solvent, like nail polish remover. It can get to be that, but often there's this fruity smell to the breath and to the urine, because keto acids are urinated as well. So no key to open the doors, no insulin, no glucose gets into the cells, it leads to hyperglycemia. In type 2 diabetes, what happens is the cells become resistant. You can imagine that if you were constantly introducing sugars, especially simple sugars, if you eat a lot of sugars that don't take very much to process, then the amount of glucose in your blood goes up very rapidly, and it spikes, and you release a lot of insulin in response to that spike. This is called a high glycemic index food. It's foods that have simple sugars. And so you release a lot of insulin, which then opens a lot of these channels for glucose into the cells, and the glucose goes into the cells by a diffusion, but the cells don't want it. The cells don't need any ATP at the moment. Their glycogen stores are full. If it's muscle cells and you haven't been exercising, then what's the muscle cell going to do with that glucose? Its ATP stores are full, its creatine phosphate stores are full, and its glycogen stores are full. It can't use this glucose. So it doesn't want any more. So it downregulates the number of channels and receptors to insulin, so that it can manage how much insulin's coming in, or how much glucose is coming in. So in the presence of repeated high glycemic index, it spikes all of this. And if you couple that with a sedentary lifestyle, with not burning the ATP, then you downregulate the receptors to insulin. So it's like, okay, I don't want any more glucose in my cells, I'm changing the lock. I don't care how many keys you have, how much insulin there is, I'm changing the locks, boarding up the doors. So who does this happen to? It happens to people that live a sedentary lifestyle, that have high amounts of sugar. Obesity is a big factor, and for some reason especially abdominal fat. And as people age, their eating habits maybe don't change, but their exercise habits probably do, and so this goes up. And these things are progressive. This takes time to develop. So more in the elderly. Now, the other thing that happens, and it happens supposedly more in men than women, but I think that women are catching up. Cortisol, the stress hormone, causes gluconeogenesis and glycogenolysis in the liver, so it exacerbates the problem. So somebody that's stressed and drinking doubles and eating donuts and not getting enough exercise and all of those things together lead to a hyperglycemia when the tissues don't want the glucose, and so the tissues downregulate and become resistant to insulin. Now, how your body reacts to that has a genetic component. So type 2 diabetes tends to run in families because genetics plays an important role in how you downregulate and how cortisol affects you and how much gluconeogenesis is going on, et cetera, et cetera. So there's a strong genetic link with an environmental components. So it's multifactorial. Now, the 3 Ps are more subtle. They might actually be absent. You probably will pee a lot more, but you may not have the polydipsia and the polyphagia. Like you may not want to eat as much, although it's hard to say. The changes are more subtle in any case. Now, like I've already said, at first you get a decrease in the number of insulin receptors, and we call this the insulin resistance part. So when you get fewer receptors, you get fewer transporters, and less glucose moves in. And the hyperglycemia that results from that causes an increase in the amount of insulin produced, which really doesn't have very much effect. It actually increases the insulin resistance, so it becomes a positive feedback. Now, at a certain point, the pancreas kind of gives up. The pancreas becomes exhausted, and it starts to regulate where it needs more and more stimulus to produce the insulin. So therefore, at a given stimulus, less insulin is produced. So the amount of insulin at first goes up, and then it goes down. Now, these people still are producing some insulin, and some of these transporters are still working, so there's less ketoacidosis. People don't get ketoacidosis. They're more prone to something else, and we're going to leave that to you to bring up in the discussion board. I'm going to be, again, interested to see what your research shows about what's more common for type 2 diabetes mellitus people to get. Now, another type of diabetes is something called gestational diabetes. And gestational diabetes happens during pregnancy. So it's a glucose intolerance during pregnancy. There's an increased insulin resistance, and it's got to do with weight gain, and it's got to do with placental hormones and a few other things. And when you're pregnant, the body requires 2 to 3 times more insulin than when not pregnant because of the demands of pregnancy. So what happens is you end up with an insulin resistance that basically mimics a type 2 diabetes. So what are the risk factors for people with gestational diabetes? Obesity, a history of previous gestational diabetes, previous babies born at more than 9 pounds, glycosuria, so people that are hyperglycemic anyways, family history will do it. And this is a very real problem. And it's a problem not only for the mother, but it's a problem for the unborn baby if mom has gestational diabetes. So we test for this, and we test for it in weeks 24 to 28 because that's when the baby is growing the most, and that's when this seems to rear its head. So what happens if you don't treat the gestational diabetes? Well, the baby ends up a little hyperglycemic and can end up with some metabolic abnormalities. It can result in stillbirth because there can be severe metabolic abnormalities. Macrosomia is probably the biggest thing, which really just means big body, because you can imagine what's the baby going to do with all of this extra sugar that's coming through the placenta. Why? The baby is growing, and so it's going to be releasing insulin, and insulin growth it mimics growth hormone, so babies get really big. And so they call that macrosomia. The newborn can end up having a hypoglycemia because blood sugars will crash because they're used to this high blood sugar, and when that's removed, they end up with a crash. It can be a dangerous thing for the newborn. To the mother, if she's had this gestational diabetes, that puts her at a much greater risk of developing type 2 diabetes, and maybe as far as 5 years postpartum with it. So along with this macrosomia, big babies, which are very difficult for vaginal birth, you can end up with something called shoulder dystocia, which really is the baby unable to pass its shoulders through the birth canal. Once the head is engaged, the shoulders can't come, and it takes manipulation. It also puts women at risk for preeclampsia, eclampsia, which is that increased blood pressure that we talked about a couple of sections ago, a couple of units ago, with the edema and proteinuria and that kind of thing. So this is a very real and very dangerous situation. So having diabetes, type 1 or type 2, can lead to some complications, acute complications and chronic complications. So acutely, it's acute hyperglycemia, and all the things that high blood sugars can do. And I'll let you read about the factors of that in your textbook, but it's the hyperglycemia leads to neurological things and all kinds of osmotic gradient changes and things like that. Ketoacidosis is another acute thing that can happen in type 1 diabetes. So this diabetic ketoacidosis, and that's a metabolic acidosis. And again, we've talked about that in AMP, and we've talked about that in the respiratory disorders, and we've talked about it a number of times, where you have this ketoacidosis. Now in type 2, and this kind of answers that other question from a couple of slides ago, type 2 people can get non-ketotic hyperglycemic hyperosmolar coma. And this is what I was getting at this hyperglycemia screwing up osmolarity and affecting the central nervous system. And it can actually induce coma. With hyperglycemia, you can get infections. Obviously, pathogens have gotten more food. Nausea, fatigue, blurred vision. Those are all very common acute things that people with diabetes have, especially when it becomes unmanaged and they become temporarily hyperglycemic. Now, the chronic complications are basically can be broken down into a couple of categories. There's vascular complications and there's neurological complications. So in the vascular complications, you can have the macrovascular and microvascular. So macrovascular is the large blood vessels. And this can lead to damage of the tunica intima of the large vessels. It can lead to problems like deep vein thrombosis and coronary vascular disease, things like that. Where this becomes really dangerous is what it does to the heart and what it does to the brain. So it increases the risk of stroke and coronary heart disease because of the damage, right? Pulmonary as well can be damaged this way. Now, the microvascular is what gets more press. Microvascular is the basement membranes of the capillaries getting thick and less exchange happening across them. And then this has profound effects on the internal respiration and the ability for the capillaries to feed tissues. It has problems with perfusion and therefore oxygen and nutrient delivery. And this oxygen and nutrient delivery affects the things that are most sensitive to that. And really, so that's the retina and the kidneys are the big things. So a chronic complication, vascular complication of diabetes is blindness from retinopathies. If the neural tissue of the retina dies, then it can't be replaced. Kidney disease is a very common complication of diabetes. These kidney nephropathies can end up thickening these glomerular basement membranes, and so the GFR goes down and the kidneys stop working. It can lead to end-stage renal disease. A very close friend of the family had diabetes and had a lot of trouble getting it under control and managing it, and he ended up with kidney disease, ended up end-stage renal disease. He was on dialysis for a number of years, and what eventually killed him was not the diabetes, but rather kidney disease. His kidneys failed. Now, in the time that it took his kidneys to fail, he ended up with various gangrenes in the extremities. He had a foot amputated, he'd had toes amputated on the other side, he had fingers amputated, all because of this lack of perfusion because of the microvascular disease in the extremities. So the other problem is neuropathic. Now, sometimes there's a line between what's microvascular and neuropathic, but basically, big problem is autonomic dysfunction. So GI disturbances, tachycardia, postural hypotension, sexual dysfunction. So the sexual dysfunction, erectile dysfunction, is both a vascular and a neuropathic thing. There is a loss of the ability for the autonomic nervous system to regulate blood flow adequately in the organs to match the demands, both from a vascular point of view and from a neurological point of view. In the central nervous system, actually regulating the autonomic nervous system. And something you'll hear about a lot and you'll see a lot are the sensory dysfunctions. So carpal tunnel syndrome, various paresthesias, lack of sensation, especially in the feet. And this becomes a real problem with people with diabetes because they don't feel their feet, they don't feel cuts, they don't feel pain, they don't feel blisters and such. And you combine that with not enough perfusion, so vascular problems, wounds don't heal very well, and infections are greater because the amount of sugar that's available for the pathogen is up. And it can lead to gangrene. Gangrene is a very common thing, especially in the feet, from untended to foot ulcers. Untended because they don't feel them, ulcers because of microvascular issues. Amputation is a very common way of dealing with this, and it's probably the leading cause of amputation in modern times. So we're going to continue with the rest of the slides in another video, and I will post that in week 13.